It's wonderful to have all of you here for yet another cardio colloquium where we will discuss the evidences regarding RAS inhibitors, especially in the post-MI space. And to facilitate this discussion, it's a pleasure to invite and Dr. Atul Abhyankar, who's going to be the moderator here today for us. That is the Director of Interventional Cardiology at Mahavir Institute, Surat, and a consultant at Heart First Cardiac and Vascular Center. So we welcome you here today for this wonderful discussion. Apart from that, we have our expert panel of Dr. Abhishek Tripathi. Sir is a DNB cardiology senior consultant and interventional cardiologist at Zydus Hospital, Ahmedabad. And Dr. Sunil Jatania, sir is again a DM cardiologist, consultant interventional cardiologist at the Anjana Heart Clinic, Mumbai. So we welcome all of you here, sir, today for this discussion on optimal selection of RAS blockers, especially in the post-MI patients. Over to you, Dr. Abdankar.
Thank you. So shall I share the slides?
Yes, sir. I've stopped sharing. Yes, sir. The slides are visible, sir. Please go ahead.
Okay. Yeah. So basically, I'll just give a brief sort of context so that then we can discuss in relation to certain questions subsequently. So these are there are various sort of options of how to treat the patients post MI in terms of survival, in terms of heart failure, in terms of LV dysfunction. So these are starting with the trials, which are way back, so kind of 20, 25-year-old trials. But since recently there have been specifically no new trials related to this. So these are very relevant trials. The optimal trial of 2002, where losartan 50 milligram was compared with captopril, and I will kind of look at the outcomes. So there was no significant difference. And the Valiant trial, where valsartan and captopril was compared, and also a combination of valsartan and captopril. So looking at the optimal trial, if you look at the primary endpoint, that there was no significant difference in the mortality. But numerically, if you see that captopril was better, although it was not statistically significant. So considering this finding, although not statistically significantly different, but still the captopril fared better. And therefore, not losartan, but captopril would be recommended. If you look at the secondary endpoint of sudden cardiac death, then also the captopril was better. The reinfarction was not very different. Looking at the Valiant trial, the mortality, it is all-cause mortality and cause-specific mortality, which I believe cardiovascular mortality, was similar in the three treatment groups. So there was no specific sort of superiority of any over the other. And as was mentioned earlier, the combination was actually the adverse events were more. So the secondary endpoints were also sort of similar in all the groups. Coming to the present interest, I mean, recently we have been treating all patients with left ventricular dysfunction or heart failure with LV dysfunction with ARNI. So that has become now the most kind of favored treatment in terms of patients with heart failure. But what about patients treated with ARNI for acute myocardial infarction? That is the Paradise MI trial. So these were the patients which between first day to 7 days with left ventricular ejection fraction of less than 40% and or pulmonary congestion. And there were 8 risk enhancers. So any of the risk enhancers was required to be included. Major exclusions were low eGFR, previous heart failure, and clinical instability. Now, if you look at the outcomes of primary endpoint, that is death, hospitalization, and outpatient heart failure, then you will see that the sacubitril valsartan did numerically better, although it did not reach statistical significance. So the primary outcome was slightly better with ARNI, but ramipril did not do uh, any significantly inferior. If you look at isolated endpoints, there were no statistically significant difference. So cardiovascular mortality, heart failure hospitalizations were similar. The outpatient heart failure tended to be kind of slightly better with ARNI, but again, the statistical significance was not reached. If you look at the adverse events, then there was definite superiority of ramipril in terms of hypotension. So the hypotension was lesser. But if you look at the incidence of cough, then ramipril had a higher incidence of cough. So, to some extent, disappointing considering our experience with ARNI in other subsets of patients, that the ARNI did not result in significantly lower rate of cardiovascular mortality and heart failure. So, this was kind of somewhat not what we would have expected looking at this thing, but consider that this was a slightly different subgroup. This was patients with MI, and the medication started in very early phase. So these are various sort of headlines related to that. So what about ACE inhibitors specifically in the post-MI trials? So we have selective trials, that means specifically looking at these, and a slightly broader indication sort of trial. So if we look at the SAVE trial, again very old trial, this was patients of MI with ejection fraction of less than 40%, randomized early between 3 to 16 days. But again, this was a trial which was against placebo. That means captopril versus placebo. And here, over a mean period of 36 months, the captopril group showed 19% reduction in mortality and 25% reduction in the recurrent MI. The LV enlargement also was reduced, and this happened in the subgroup of whether the patients were thrombolized or were given beta blockers or not. Today, we obviously don't have Trendolapril available, so not go into detail, but just to show that another trial showing 25% reduction in mortality and 15% reduction in the recurrent MI and 20% reduction in certain cardiac death. So they were the other evidences, that means the other this thing which were with broader indications, the ICIS-4, which showed that captopril was effective in reducing the 5-week mortality. The survival advantage appeared to be also present in the long term. GC3, lisinopril, started within 24 hours of MI. There was a decrease in mortality and severe ventricular dysfunction. CCS1, the anterior wall infarction of captopril treated group was found to have lower mortality. So patients with anterior MI and compared with captopril versus placebo, it was better. These are kind of a combination of studies. So one study and then its extension. So this is the AIR study, that is acute infarction ramipril study. This was in the setting of acute MI. Again, the patients were randomized in the early phase, that is between 3 to 10 days post MI. Again, this was a comparison of ramipril versus placebo, not with any other drug. The initial trial period was 15 months, and which showed that there was a 27% relative risk reduction in mortality. There was also a 19% reduction in rate of MI and stroke at 6 months. Now, the AIR extension study, which was the subset, the follow-up was for 42 to 59 months, which showed that the beneficial effects of ramipril, which had started early after MI, were sustained after 3 to 4 years, despite continuation of medication at 1 year, with a relative risk reduction of 36 and an absolute risk reduction of 11%. So, in terms of number needed to treat, treatment of 9 patients for an average of 1 year with ramipril would result in one additional survival up to 5 years. Now, the very long term, that means in terms of almost like 30 years, if you look at the air survival study, which is looking at the mortality, the median survival time was 8.3 in the placebo and 9.6 in ramipril. So 14.5 months of life was added by starting ramipril in the post-MI subset. The survival curves cross at 14 years from time of randomization, and the life expectancy was greatest at about 15 years. And this was kind of the benefit which was across all comorbidity groups. So this is the comparison in various groups, whether it is in diabetics, whether it is in previous MI. So not going into each and every statistics, but to show that the various clinical subsets, the benefit was still present. There was a substantial survival gains with ramipril with treatment for 15 years, even after the blinded treatment allocation. For every day a patient received ramipril, uh, on an average, his or her life was extended by 1 day. So 1 day the patient took ramipril, there was extension of life by 1 day. And relative risk of survival for patients with diabetes particularly was increased by 54%. So basically, treatment with ramipril for 1 year when started early post-MI in patients with heart failure resulted in survival benefit, which was not only up to 1 year but extended far beyond that 1 year. Uh, So if you look at various things that one should use post-MI, then we know that we've seen a lot of evidence till now that early initiation of ACE inhibitors in the first 24 hours or early phase of MI is useful. Initially, when 35 years back, when I was a DM student, there was actually a recommendation to give beta blockers, especially IV beta blockers, in immediately in acute MI phase. Over a period of time, we learned that this is actually not useful but rather harmful. And then we also had one large Chinese study, Comet, which showed also that beta blockers in very early phase are not really useful but may be harmful. There is also an agent which is not commonly considered, but which clearly shows that MRAs also are beneficial in early phase post-MI. Uh, then I think since we are today focusing, I will not go into details of at what phase other drugs would be useful. So, but early, what we have seen till now is that early ramipril or early ACE inhibitor is very useful. So this is from the Jack, that on based on the various trials that we just discussed, that the ACE inhibitor should be administered within first 24 hours for heart failure patients with ejection fraction of less than 40%. They have significant survival benefit. So if you look at the ESC guidelines for management of ACS in patients presenting without persistent ST elevation, then ACE inhibitors are recommended in patients with, of course, or ARVs, in patients with heart failure with reduced ejection fraction, diabetes or CKD, unless contraindicated, to reduce the all-cause and cardiovascular mortality and morbidity. Uh, these are the recommendations for RAS inhibitors in the latest 25 guidelines released in just February. That class 1A indication, that in high-risk patients with ACS, that is less than 40% patients with hypertension, diabetes, or STEMI in anterior location, oral ACE inhibitors or ARB is indicated to reduce all-cause mortality and MIS. We will not go into the other drugs. So I think having just briefly set the context, now I think we will have discussion, and we have the expert panel. And so I will just probably just pose the questions, and then which are kind of addressed to a particular panelist, but of course both can comment after the first one has answered that question. So, is it okay to go ahead, or anybody from the organizers want to say anything in between?
No, sir, please go ahead.
Okay. So the first question to Dr. Abhishek Tripathi, that in the post-MI patient, post-revascularization, at what systolic blood pressure would you initiate ACE inhibitor therapy? And what is the starting dose that you would recommend? And how do you up titrate this dose? Dr. Tripathi, and then, of course, it is open that it can also be answered by Dr. Sunil.
Yeah. So, good evening, everyone, and good evening, Atul sir. Answer to begin with this, like the in patients post MI, post ST elevation, most of the time when we take the patient out of the cath lab after doing the primary angioplasty, I see two, three things. One thing, basically what was his basic biochemistry, like what is his creatinine, potassium, all these things. There's no absolute contraindication. Is my patient in his gross heart failure needing aggressive dose of diuresis? If not, LV dysfunction is there. If yes, and blood pressure more than 120. So to summarize, if blood pressure is more than 120, patient is not in gross heart failure, needing aggressive diuresis, and there's no absolute contraindication. After wheeling the patient out of the cath lab within 6 hours, start with ramipril 2.5 milligram. If blood pressure allows, I write 2.5 milligram BID if blood pressure remains more than 120. So every second dose would be titrated. If the BP is more than 120, it will be given. If BP is less than that, they will not give. So for starting, as far as when to start and what is the blood pressure marking, I keep the blood pressure marking for the initial 48 hour around more than 120. So starting dose is usually to start with 2.5 milligram. Sometimes if the blood pressure is maybe hovering around for the next 24 hours around 106, 110, 112, not going more than that also and not less than that also, I start with Avimil 1.25 milligram BID also. That is available also, and I start with that, at least with that small dose to build up on the dose. For titration, I wait for the next 48 hours. Suppose if BP is going very high, I have the liberty to escalate the dose. But in majority of patients, it takes 48 hours to stabilize the hemodynamics as well as to stabilize the first 2.5 milligram BID dose, and then I increase the dose maybe to 5 milligram. Maybe initially morning 5 milligram, evening only 2.5 milligram. I will not jump to the 10 milligram in the first 48 hours in the first 7 days. So 2.5 milligram BID would be my choice. If hemodynamics doesn't allow, maybe 2.5 milligram OD, then increasing to PD after 48 hours. If 2.5 milligram BID was allowed by hemodynamics, then to 5 milligram in the morning and 2.5 milligram in the evening on the second or third or fourth day. This is how I go about it.
Any comments, Dr. Sunil?
Yeah. First of all, Dr. Atul, you just shocked me by saying that 35 years back you were a DM student. And sir, you still look 35.
Thank you.
So, Dr. Abhishek has very beautifully covered the approach that he does. I agree with him in most of the things. Few things that I do is, for me, starting a ACE inhibitor in the first 24 hours is a big thing to be started. So even if the BP is around 100 and beyond, I don't hesitate starting a very low dose, how like Dr. Abhishek said, 2.5 milligram of ramipril, even a half dose, and that too at night time. So I do start within 24 hours. And the rest all thing, I agree with what he said. We up titrate in the initial 1 week. We discharge and we call first follow up after 1 week. So till that 1 week, even if the BP is slightly on a higher side, I am fine with that. So the up titration, like 2.5, 5 milligram is good enough to discharge with. But of titration, if needed for the BP, I do it only after 1 week. So most of the things I agree with what Dr. Abhishek said.
Yeah, I mean, just to add this thing that finally, post primary PCI, it is the hemodynamic status that basically will determine as to how early one would start. The I don't know. I mean, from the slides or even I'm not exactly aware of. See, the trials had a relatively, most of the time, a slightly broader time interval post MI of inclusion. So I'm not aware if there is actually any data of sub-analysis of patients which were started on the first day versus patients which were started between 5 to 7 days or so. So actually, that would be a very interesting thing if the trial actually has that information. And I would request the industry people to, if they can provide, because just going through all this data and looking at this question, I think if you actually look at the patient split between started within first 24 hours versus little later, that actually might tell us whether it is really in patients, especially who have borderline blood pressures, whether it is worth starting it that early. Of course, uh, in a reasonable period, no doubt about that. So the next question to Dr. Sunil, will you switch the patient to an ACE inhibitor if the patient at the time of MI is already receiving an ARB for hypertension?
So I'll take up this question instead of saying just yes or no. I'll take up as a discussion. Like, see how it is like ARB and ACE inhibitor. In comparing these two drugs, as you had rightly pointed, we have only limited study. Like, for example, Optimal that had losartan in it, and we have that Valiant that had valsartan in it. And losartan and valsartan are not the ARBs that we are using these days. So yes, ARBs are ARBs, but we cannot just put all ARBs into one category and say yes to be switched or not. That's one. Second, except for of course, the latest guidelines are saying there is no need to switch. The latest thing that is there. And lastly, so it's almost the guidelines say you have to start either ACE inhibitor or ARB. And lastly, what I want, the ACE inhibitor, we have a very long, robust data over ages to justify the use of ACE inhibitor. And ARB, we have limited study. But yes, the guidelines say there is no need to switch. To ACE inhibitors if the BP and all that is permitting. If not permitting, the hemodynamics are not here. And as I was saying, a low dose of ACE inhibitor is a good to go for me in the first 24 hours. This is how I approach.
Dr. Abhishek, any difference of opinion with that?
No, I totally agree with Dr. Sunil Bhai here. What I see, suppose if the patient has hypertension, if the ejection fraction is not bad and blood pressure is allowing ARB, I would probably not change. But in most of the patients, the ejection fraction goes down and the hemodynamics also goes significantly, it changes. Majority of patients, those who were hypertensive, they usually don't require anti-hypertensive or BP control at least for the next 24, 48 hours, sometimes 72 hours. And we have seen after, say, taking the patient out of the cath lab, when the patients are there in the ICU. So that is the time if patient's blood pressure is the EF was good and BP is allowing, definitely I will not change. But if the EF has come down and now BP is not allowing, and my purpose of giving some medicine is not the blood pressure control, rather to prevent the LV remodeling, then this is the best time for me to switch the patient from ARB to ACE inhibitor. And now for the next period of time, I will keep the patient on ACE inhibitor. We'll titrate the ACE inhibitor, and we'll see how in the follow-up, how the LV is revolving, how the LV is coming back. And then I'll decide in the course of follow-up whether I need to switch back from ACE inhibitor to ARB or not. So this is how mostly it is a play of hemodynamics, LV function, heart failure, ejection fraction, and the blood pressure, and the purpose of giving ARB versus ACE inhibitor. If the LV has gone down and if BP has gone down, and the purpose is not to bring the BP from 150 to 140, rather to keep it around 110, 120 and prevent LV remodeling, I'll probably switch to ACE inhibitor in these patients.
Yeah, absolutely. And previously, one of the sessions that I was involved as a faculty, we had a 50-50% split on this question as to whether where you should switch or not. But I think in medicine, actually answering these questions in terms of yes or no is a very difficult thing. Because I mean, if you ask me that if this is a large anterior MI, EF has gone down versus a patient who has a inferior MI where only some PD is involved and practically there is no difference in, I mean, the echo looks fairly absolutely like normal echo. So I think there will have to be adjectives to decide, how do you answer this question. But I mean, it was good to discuss this as to in terms of how one would do it. So the next question to Dr. Abhishek again. Uh, how early you think that ARNI can be initiated in patients with post-MI?
So, this is also a beautiful question. Like in paradigm HF, we have seen that in all sort of LV dysfunction, the ARNI, they work. Now, the different studies, they have also come, like in de novo patients also, we can start these patients in the hospitalization, in the first de novo heart failure also, we can start ARNI in this patient. But then Paradise HF, it showed there is no superiority, but there is no inferiority also. So again, this is a complex thought which comes in our mind whenever we see a patient like this. Like if the patient, then in Paradise HF, there was no superiority, no inferiority compared to Ramiprid. But outside hospital, OPD basis heart failure was a lesser in trend in ARNI compared to Ramiprid. How I see in these patients, if my patient has just LV dysfunction, EF around 30, 35, 25%, no gross heart failure, does not require an aggressive diuresis, anything like that, and blood pressure is allowing, I'll probably go with ACE inhibitor and Ramiprid in these patients. If my patient had a symptomatic heart failure where I needed maybe 1 or 2 days of diuresis to bring my patient up, and now when the diuretic dose is getting stabilized, I will start this patient depending on other parameters like blood pressure and electrolytes and biochemical parameters. All I will put this patient on ARNI. Now the complex thing, the different thing which we need to understand, the problem in heart failure, de novo heart failure, secondary to MI, is the coronary artery disease. If we have fixed up that thing within the window period in effectively, there are good chances that LV will recover by virtue of improving the flow in that territory rather than the mixed play of drugs. So if you have done a reasonable good angioplasty, primary angioplasty in the reasonable time, LV is going to improve. In that time, we are giving ACE inhibitor or ARB. If LV is improved, so you can continue with patient with ACE inhibitor. Now the question comes, what happens in these patients in the follow-up? Suppose we have started the patient with ACE inhibitor after 4 weeks and 6 weeks, the ejection fraction remains 15%, 20%, 25%. Now, if it goes from an acute de novo heart failure to a ischemic but chronic heart failure or a compensated LV dysfunction, then again we have to switch the patient for ACE inhibitor to ARNI. So to summarize, like in my patient, as I mentioned, if there is LV dysfunction, no gross heart failure, hemodynamics are allowing on the day one, Ramiprid comes. If the gross LV dysfunction, maybe cardiogenic shock, some pulmonary edema, I have diuresed the patient and the heart failure has taken significant attention of mine, I will start with the ARNI drug. In those patients where I have started with ACE inhibitor, now in these patients in follow-up after 4 weeks, 6 weeks, when the LV recovers to normal, I will manage that part with ACE inhibitor for blood pressure and to prevention of further LV remodeling. If the LV remains less than 30% after 4 weeks, 6 weeks of echocardiography, those patients on ACE inhibitor, I will switch those patients on ARNI.
Yeah, I mean, if you look at the Paradise MI, it actually, I mean, ARNI did not win hands down, but it was numerically actually better. So if, except for the fact that ARNI would probably is likely to cause more hypotension, especially in the post-MI period. Otherwise, I think the data, although you can say that statistical significance was not reached, but in all aspects, numerically, it was kind of superior in Paradise MI. Any other comments, Dr. Suni?
Fortunately, Dr. Abhishek covers it so beautifully. There is hardly anything left to be shared. For me, it is a ACE inhibitor first, and then for follow-up and then decide. Yes.
Okay, so then now the question to you is that post revascularization, if you find that there is LV systolic dysfunction, that is EF less than 40%, but without clinical heart failure, would you use ACE inhibitor or ARB?
Yes. See, fortunately, even this part he had covered. So post revascularization means the coronary jobs, we assume it's beautifully done now, and still the LV dysfunction persists. So in this scenario, definitely there is now role of drugs that will come in, and not just is the vascular component that is already dealt with. Now, the only thing is how much the patient's hemodynamically he'll tolerate. What I want to say is the studies that Dr. Abhyankar shared here, sir. In these studies, essentially, it's the dose also that matters. It's not only the ARNI not started. It's not just yes or no. The dose that they have mentioned is 200 milligram BID. Now, how many
Think
is a
we lost.
long-term outcome. So definitely based on hemodynamic and the tolerability. Tolerability, I mean two things. One, hemodynamically, whether BP and all that is permitting or not. And secondly, creatinine, potassium, and all those factors. So side effect part permitting or not. So if you can up titrate, good enough. Otherwise, we can start with the ACE inhibitor and then switch over to ARNI if the EF stays low when we call the patient for follow-up after 1 week.
Yeah, I mean, just to mention, since you mentioned about this thing, the study was designed for optimally using 200 milligram, but actually it was not necessary that every patient had to receive 200 milligram. So, as a matter of fact, we were a part of Paradigm HF. In Paradigm HF itself, Indian patients, many of them did not attain the goal of 200 milligram. But the good part with Paradigm HF, this is not in context of MI, was that even lower dose of ARNI produced benefits. So a lot of patients, especially in our patients, we were not able to take the patients to 200 milligram twice a day, but still they seem to get the benefit.
What I
So
would like to add here is, okay, in fact, I don't know, I would like to know from others also, how many of our patients who require ARNI actually are able to tolerate 200 milligram BID? Not related to that question, but in general, like for my patients, very few actually are able to tolerate that high dose. And 100 BD is the maximum that I'm able to achieve for most of my patients. I would be happy if you all can share your experience also on this.
no, I mean, I totally agree. I mean, I think maybe 5% or so patients are able to tolerate the dose of 200 milligrams.
Exactly, exactly.
The majority are on 100 milligram twice a day.
Exactly. And they show good results even with, as you rightly said, very low dose. Very low dose also they give good results in improving the EF.
Yeah. No, I mean the trial itself showed that even those who were able to take the lower dose still got the benefit. So okay, so I think these are kind of the open questions. In the post MI patient post revascularization, when do you like to start a beta blocker? Which will be the preferred beta blocker? At what dose you initiate initiate and how do you up titrate? And do you advise ACE inhibitor and beta blocker combination? So anybody can go first.
I
So
think both of us are available. Sir, you only push the question to one by one to us.
Okay. So this will reverse this thing. So Dr. Sunil first.
Yes. So post MI, if patient is in failure, then definitely beta blocker is little late to push in. Okay. So if the post-MI patient is not in failure and all, ACE inhibitor definitely comes the first drug in. But I would prefer to start beta blocker in the first 24 to 48 hours. Heart rate, BP, no failure, all that permitting. And definitely before hospitalization, patient should have a beta blocker on board.
So all the questions, which is your preferred beta blocker?
Okay, most of the studies that are there, the studies are with metoprolol. Okay. Now, if the patient is in heart failure or patient is asthmatic or some reason like that, and you cannot start a metoprolol, then bisoprolol. Or if the BP is not permitting to start metoprolol, low dose of bisoprolol also can be started. But otherwise, a good study that we have is all with metoprolol. So metoprolol is my first choice. But because of asthma or failure or this BPA not permitting, that bisoprolol is also a good drug to begin with.
Yeah, just to
Lastly,
add to that, probably I would consider bisoprolol in patients who have significant tachycardia, persistent tachycardia, because the heart rate reduction part is much better with bisoprolol than other beta. But otherwise, I mean, I agree, metoprolol, if patient has LV dysfunction, carvedilol has evidence. I don't think that there is anything wrong if somebody starts a particular beta blocker. But probably, as you said, more data with metoprolol, and now a lot of data coming with bisoprolol, and especially those patients maintaining high heart rate, bisoprolol is better. Uh, Dr. Abhishek, anything you would like to?
So, when to start a beta blocker if the LV function is good. And one thing, second, if arrhythmias are bothering me, like if there is a frequent PVCs are there and short runoff and SVT is coming, which we commonly see post revascularization. If the patient is not in gross failure, I'm not using a heavy dose of diuretic. The beta blocker comes again in my practice. I start in the first dose by night. By evening time, the beta blocker will be there unless the patient is in gross failure and we are titrating still with either the patient is on inotrop or some precarious hemodynamics are there, only then the beta blocker will wait for 24 hours and then it will come. As far as the preferred beta blocker is concerned, so how I go about it, as Abhay sir also mentioned, like my choice nowadays is bisoprolol in most of the patients. If the arrhythmia I am bothered with, if the heart rate is I'm bothered with, if the hemodynamics also on the lower side I'm bothered with, bisoprolol comes pretty handy in these things. Only when I consider using metoprolol when I want a shorter acting beta blocker, then I would use a short acting beta blocker, metoprolol, just because if I'm not sure how he's going to behave after 12 hours, if the patient would develop some hypotension or is going towards a shock kind of thing or not. Because tachycardia sometimes becomes very tricky. As we know, tachycardia is sometimes a pre-heart failure condition where the cardiac output is maintained at the virtue of heart rate. Stroke volume is not there. So we have to selectively and individualize those patients that whether this tachycardia I'm going to decrease just because to prevent the adrenergic effect, or whether this would also cause by decreasing the heart rate would also decrease the cardiac output in total per minute. So those things we have to just consider. But if arrhythmia is bothering me, if tachycardia with no pre-heart failure, lungs are dry, I would go for bisoprolol. Precarious hemodynamics, and I'm not sure what will happen after 12 hours, and I still need to control the heart rate and control arrhythmias, a short-acting beta blocker or metoprolol. Carvedilol, I need to have a good blood pressure reserve. Like any as Abbas had mentioned, anybody using any of these three first-line beta blockers is right. But we use our experience also, how we have seen, what is our experience, what is our comfort. Carvedilol, I've seen I need to have some blood pressure margin. Very good molecule. Again, short acting like beta blocker, like metoprolol, but I need to have some margin because of its alpha 1 blocking activity, it certainly decreases blood pressure. So as I mentioned, preferably bisoprolol, if not then short acting metoprolol. The dose how we initiate bisoprolol never more than 2.5, maybe even 1.25. If it is metoprolol succinate, it is 25 only. And then before every second dose of beta blocker for the first 24, 48 hours, we would put a margin. Then when do I need to give and when do I need not to give? Instructions are very clear for staff. There should not be any messing around with these two molecules like imipramine and beta blocker in the first 48 hours. There should not be any unnecessary dosing. There should not be any required dose which was missed.
So, what about the combination?
Combinations are, we already have these combinations. Ramipril and metoprolol combinations were there. If you are aware, the DGCI just 15 days back, combination of 2.5, 25 milligram combination. The 5 and 50 combinations are there. Like 5 milligram Ramipril, 50 milligram metoprolol is there. But 25, 2.5, all combinations, they have been removed. So I don't know but exactly. We would like to know from the managing people what kind of doses they are planning to bring, because they also must be aware that 25, 2.5, the government has withdrawn that molecule.
Right. So, question to Dr. Sunil: do you consider anti-proBNP as a deciding marker for choosing ARNI over RAMP?
Anti-pro-BNP, I don't do routinely for every post-MI patients unless I clinically feel the patient is having some failure component or all that. Then only I do. Routine as a marker to decide about ARNI and Remipril is not what I'll be doing. You, you
Uh,
all you all do that way, do anti-pro-BNP and then decide about ARNI and Remipril.
Not necessarily to decide between ARNI or Ramipril, but probably anti-proBNP. We do anti-proBNP in a lot of patients, but if anti-proBNP is significantly elevated, I think ARNI, the evidence is more in favor of ARNI over Ramipril. But it is not that I would want to do anti-proBNP for this decision.
Not
That's
for
not
decision,
very,
exactly. Failure component, ARNI as a upper edge.
yeah.
Agree with that.
Yeah. So, Dr. Abhishek, will you start ACE inhibitor in all patients with ACS, whether revascularized or not, to get mortality benefits?
Certainly, yes, if there was a LV dysfunction. If there was no LV dysfunction, then it doesn't have any mortality advantage. But if revascularization was done or not, medically managed or whichever way, if LV dysfunction is there, recent ACS is there, definitely every patient would be on ACE inhibitor if there's no contraindication.
I think we partly this question we already discussed. What percentage of patients tolerate ARNI 200 versus Ramipril 5-BD? So I think we already answered this question that ARNI 200 BD, very few patients tolerate. So unless Dr. Sunil, you want to add anything?
I absolutely agree. 200 ARNI BID, it's like, most of the patients of mine, they don't tolerate. So I will be, as you rightly said, 5% of your practice. I won't be able to tell the percentage, but definitely very small number would tolerate ARNI 200. 100 BID is good enough a dose for me. Similarly, Ramipril 5 milligram BID. Uh, I prefer going with multiple drugs at a lower doses rather than stepping up one drug with the maximum tolerated thing, exhaust that drug and then go for the next drug. So Ramipril also a 10 milligram and all that I don't do in my practice. How about y'all going Ramipril 5 milligram BID routinely?
If you just compare the percentage, then as a ballpark figure, I said 5% for ARNI. Maybe 30 to 40% people can tolerate. I'm not talking whether I would want to necessarily increase or not, but in terms of how many people will tolerate 5 milligram
Agree.
BD, then probably 30 to 40%.
And
Sir,
in our
but
routine, do we go for 5 milligram BD and like that doses in all our patients? As
Ideally, one should, because the evidence suggests that the benefits are better with that dose. But again, we have to individualize the patient and see the patient tolerates. What about the combination with other drugs? What is
correct.
the effect in terms of the combined effects on blood pressure, etc. But to just purely answer how many would be able to tolerate, then that slightly higher percentage with Ramipril.
Ramipril will be better tolerated at this dose compared to Arni at this dose. Agree
Yeah,
with you, sir.
yeah, yeah. So I think that was the last question. If any of you want to sort of stop share, any of you want to make any comment, add, Uh, just to mention something interesting, I'm just sharing some of my colleagues, not that I totally believe in that. A lot of my colleagues who, after doing a delayed primary angioplasty, not primary necessarily, but delayed MI revascularization, use bisoprolol specifically, but in beta blocker, they think that the incidence of rupture is reduced with that. I'm not very sure because it's very difficult to have some kind of statistics on that. But a lot of my friends and colleagues across India, some of them believe that the incidence of rupture is lower if you give bisoprolol when you are doing delayed revascularization.
It's difficult to say because many a times we don't do delayed, and then none of us probably experience of many rupture that we can.
Yeah, the incidence of rupture is not so high that you can actually compare.
And so many ruptures to say if one has, so hats off to them.
To get that data, how many ruptures we'll have to see. So in our practice, we don't see that common, sir.
Okay, so if are there any other questions from the audience, or otherwise we can close?
Currently, no questions from the audience, sir. I think most of the discussion is already covered by all three of you beautifully. So, sir, I think we can close today's meeting.
Sure.
So, thank you so much, everyone, for joining in today. And it was a pleasure hearing Dr. Atul, Dr. Abhishek Tripathi, and Dr. Sunil on the insights of the optimal use of RAS blockers, especially in the post-MI space. So, thank you so much for this insightful discussion, and have a good evening.
Thank you very much, Dr. Ronak and MCure, for organizing this beautiful meeting. It was a mutual thing. Needn't we, of course, shared our experience, but there's always in the meeting a lot of points that we also learn and take home. So thank you for organizing such good academic meet.
Thank you, sir.
Thank you so much,
Thank you.
Dr. Atul, Dr. Sunil, Dr. Abhishek. Thanks a lot. Have a good evening.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.